Most people will have these events after they got trauma. They are not stressed now. So if somebody, for example, got traumatic life experience, has an accident, has an abuse or something like that, they had it like 10 years ago. In the heat of the trauma and the heat of the problem, they do not have any non-epileptic seizures. When they come, when they're married, they're in a safe environment, they're in a safe relationship, then their brain kind of like worries about going back and then start to cause this as a defense mechanism. So it can be something that happens later on.
All right, so Dr. Danoun, are psychogenic non-epileptic seizures seizures?
Well, first of all, thanks for having me. I'm very excited and passionate about this subject, so definitely I'd love to talk about it. Yes, they are seizures. So psychogenic non-epileptic seizures, they are seizures, and the patient has real seizures that happen. Patient will faint, will lose consciousness, will shake. We will have real symptoms that happens. But the difference between epileptic seizures, which is an electricity storm that goes into the brain and causes symptoms to happen, and the non-epileptic seizures is that when you record EEG and brain waves, the brain continues to be normal during psychogenic seizures, and the generator and the cause of it is different than epilepsy. And that's why the treatment and our understanding is different than epilepsy. But they are seizures, yes.
So if someone is diagnosed with psychogenic non-epileptic seizures, are they considered epileptic?
Well, the word epileptic has a connotation and understanding of somebody has epilepsy means that they have excess electricity in the brain and there are epileptic seizures happen. So I don't think that we can call people with non-epileptic seizures or psychogenic non-epileptic seizures epileptics, but they do have disabling seizures and they can be as disabling and even worse than epileptic seizures.
I find psychogenic non-epileptic seizures fascinating is because, first of all, there's a stigma that unfortunately that patients have to deal with. They're having these episodes that are uncontrollable, and there is a certain kind of stigma that they're living with. What are some of the things that you tell your patients who are dealing with PNEs for short when they come to see you?
Yeah, the first thing after we finish the diagnosis, which we will talk about later, but the first thing I tell them that your seizures are real, 100% real. The fact that they are psychological in nature and it happens because of different mechanism in the brain does not mean that they're fake. You're getting them to have an attention or to get out of a situation or you're faking it or all in your head. That's all wrong. They are real seizures, but the reason why they happen is different than epileptic seizures. So that's why we need to kind of approach it differently. But definitely one of the most challenging things is to understand like why they are happening and what happens to the brain. Most people, doctors tell the patients that they do not have epilepsy. So it's kind of telling you, what's your name? My name is not John. It's like, okay, it's an information, but not very useful information. Right. You don't have epilepsy. Okay, why do I fall and shake every day? So that's the problem. So the more we understand it, which we did lots of research, and now we can give them what they have, which is the non-epileptic seizures, and it's happening in the brain. And there are mechanisms that generates it, but it's psychological in nature rather than epileptic and having excess electricity.
So what I'm hearing you say is epilepsy that is caused by abnormal firing of the brain's electrical activity, that's considered that they are considered epileptic. And people who are experiencing symptoms that are very similar to these epileptic events, maybe they have these events and they're on an EEG. Is that how really you diagnose?
Yeah, let's talk about diagnosis of non-epileptic seizure. So the diagnosis journey begins with the neurologist. So we talk to the patient, do the physical exam, and talk about what symptoms they have. And it will be very valuable to see a video of the event itself, either a recorded camera or somebody record them on their phone. So that will be very helpful to have a video of the event. And then the description of the event can be different a little bit, nuances here and there between epileptic seizure and non-epileptic seizure. For example, because epileptic seizures are electricity storm in the brain, there is misfiring and then excess electricity. The area of the brain that is activated, it will show the symptoms in an exaggerated manner. So for example, it starts with like face jerking, deja vu or something like that, and then it will spread to all the body jerking, and they will be confused afterwards and tired, and maybe they bite their tongue or wet themselves and so on. So these are kind of symptoms of epileptic seizure. They last for a short period of time, like 1 to 2 minutes. In non-epileptic seizures, it's kind of different. It starts slow and builds up with time. It is on and off, shake and then stop and then shake again. It is asynchronous, means that in epilepsy you have like jerking in one plane, one rhythm. In non-epileptic seizure will be like fast, moving in and out, right and left, and it can change. Somebody will move in and out and stop and start. So these are all features of non-epileptic seizures. The eyes will be closed in non-epileptic seizures and will be open in epilepsy or rolled up. And other things, the emotion. Usually in non-epileptic seizures, people will be emotional. They might cry inside the seizure or something like that. And it can be more prolonged, like 5 minutes, 10 minutes, 30 minutes, on and off during the seizure. And consciousness and awareness can be impaired in both. But some non-epileptic seizures, they cannot respond, but they still can hear people around them, but he cannot talk or respond. These features are kind of more non-epileptic seizures and epileptic seizures. So the description of the event can give us a hint on what are we dealing with. The definite diagnosis is to send the patient to the epilepsy monitoring unit, do a video EEG, hook him up to the EEG machine, see their brain waves, and do a video to see what they do, and then have them stay in the hospital until a seizure happens. We stop medications sometimes to induce seizures, or we give them flashing of lights, hyperventilation, sleep deprivation, anything we can do to trigger the events. And once the seizure happens, then we look at the brain waves at that time. If the brain waves are showing electricity storm and kind of a very expected signature, then at that time it's like, okay, we have non-epileptic seizure, like we have epilepsy. And then if the shaking happens, we see the shaking that's consistent with non-epileptic seizure, and we see the changes in the brain that are still normal, then we see that this is non-epileptic seizure. The brain waves continue to be normal, and that can tell them apart, and that's the gold standard of diagnosis. Yeah. So once we record their typical events, all the events that happen at home, and they are non-epileptic, we call it documented. That's a 100% accurate diagnosis that they do have non-epileptic seizures.
So you see these patients on a weekly basis, right? These are your patients that you take care of.
Yeah, I see lots of patients with non-epileptic seizures. Actually, about a third of patients who come to the epilepsy monitoring unit for resistant epilepsy, they end up being diagnosed with non-epileptic seizures. So it is very common. About a third of my patients have non-epileptic seizures. And once we make the diagnosis, there are a few things that we can do to help them. The first thing is to stop their anti-seizure medication if they do not have epilepsy as well. And then the second thing, we give them the treatment for non-epileptic seizure, which is a psychotherapy and kind of programs that we help to kind of reverse these changes in the brain. And that will lead us to kind of talk about why non-epileptic seizures happen and what is the mechanism in the brain.
Right. So before we get into what the treatment for psychogenic non-epileptic seizures are, let's talk about some of the triggers. Are there any triggers that can set these events off in someone living with psychogenic non-epileptic seizures?
Yes, there are multiple triggers actually. So that goes to the cause and mechanism. So let's talk a little bit about the cause. So the cause of non-epileptic seizures can be the mechanisms in the brain that process conflicts in the emotion areas of the brain. They get out of sync and they start to kind of misfire and misconnect the brain. For example,
that's the prefrontal cortex, right? So
so the limbic system is where the emotion and memory processing happens. So you're talking about the hippocampus, the amygdala, and then connection with the frontal cortex, the dorsomedial prefrontal cortex, and so on. So this system processes conflicts and process things on the brain. And with that, usually people have a pathway out. So some people lash out, some people get angry, some people will break things, but some people are sensitive. They repress things inside. And these people will kind of keep things to themselves until it needs an outlet. And then the brain finds a way to get it out in a physical manner. And we have done lots of studies, connectivity, functional MRI, and we found there is heightened connectivity and this pathway that forms between the limbic system, the emotional processing area, and the motor cortex. So there is conflict that happens in the brain, and then this is kind of brewing inside, and that needs to be in an outlet, and it goes to the motor cortex, like kind of water behind the dam that keeps growing. Either will break the dam or will have an outlet that comes out, and then the brain for some reason starts to connect it to the motor cortex, and then every time there's a conflict, it will go into an active seizure.
Mm-hmm.
This has to do with biology, nature, and nurture of the patient. So it goes all the way back to the biology, like the genetics, the build of the brain, The biological susceptibility, like for example, people can get into trauma, and that traumatic life experiences, lots of people will have traumatic life experiences, but only 10%, 15% will develop post-traumatic stress disorder. Why is that? Because it has to do a lot with that biological changes in the brain and susceptibility, that some people will go into a disorder, some people don't. We don't understand these mechanisms very well, but we know that there is a link between these two, that traumatic life experiences and non-epileptic seizures. But only 50% of people we can identify a traumatic life experiences. Like this notion that, everyone with non-epileptic seizure, that's not right anymore. Men can have it, women can have it, young or old, anyone can have that. It doesn't have to be like a traumatic life experience that happens, but sometimes the trauma can be relative. For example, somebody has a debt on a credit card. It can be, who cares? I will pay it off. And somebody is like, oh my God, I cannot live with that debt. So devastating, and especially if it has social consequences. So everyone's trauma is different, and their reaction to that trauma can be different from one person to another. So that's why everything is relative, and biology and reaction in the brain can be different from one person to another. So the people in general, they are like more sensitive, more compassionate. They don't like, they repress things inside. They don't talk about it a lot. And that kind of leads us to the way to help them. The way we treat non-epileptic seizures is to utilize psychotherapy. The best psychotherapy that has been helpful for non-epileptic seizures is called cognitive behavioral therapy, CBT. So CBT is the cognitive part is the awareness and understanding and mastering the thought process. And then at the end of that course, we teach them the behavioral part, which is the seizure, how to get that channeled out, not going through a seizure, but going through a healthy thing that you can ground it and you can use it yourself.
What are some of the exercises that you do in that?
So the best way to structure the exercise and structure the treatment is to use take control of your seizure workbook. So there is a group that is expert in non-epileptic seizure, led by Dr. Kurt LaFrance, who is I consider my personal mentor on non-epileptic seizures.
Yeah.
And I did interview in my videos on non-epileptic seizures. So he made that book and did clinical trials actually to prove that this works. So he has a workbook of 12 sessions, 1, 2, 3 every week. They do a session with the experienced therapist, and then they apply the book, and there are homework and things like that to do. And in that book, the trauma and the events in life, they are discussed in week number 9. Talk about any traumatic life experience, because we're not ready to deal with what is hidden and what is inside. So we always start first with awareness and mindfulness and so on, and then after we have the tools, we can start to address some more difficult conversations. So definitely that cognitive behavioral therapy is a major treatment for non-epileptic seizures, and it helps very well.
Okay, so it sounds like what you're saying is that if these conflicts, if this trauma is not taken care of before they have these events, that it's highly likely that these people would experience some type of psychogenic non-epileptic event. What the book is trying to do, and what the correct course of action is, to attack these traumatic experiences, get to the root cause, and maybe guide the person out of that traumatic event, so they don't have these epileptic-like arrests. Is that correct?
Correct. So it masters the processing of conflicts, so the cognitive part, the processing and understanding and awareness. And then once we master that, then we work on the reaction and how it gets out. So instead of going to the motor course and cause seizures to happen, no, we will have grounding techniques and getting it out in a healthy way that you control rather than they will control you. So that's what the patient will do. And we have a therapist guide as well. So that's a companion book that you can get and give it to your therapist so that they can use it. So any therapist can be an excellent therapist in treating non-epileptic seizures. Not every therapist can be a very good therapist in that standpoint or their experience, but when you do the companion book, it helps them a lot to kind of use their skills into helping the patients with non-epileptic seizures.
Yeah. Well, maybe someone is watching with non-epileptic seizures and they understand that they're real. But maybe there's that stigma that surrounds them. Maybe their parents are having a hard time really wrapping their brain around what's happening. What do you tell patients, or what do you tell the parents of patients who are dealing with psychogenic non-epileptic seizures?
Yeah, first of all, it's they can help their loved one a lot by supporting them and we can help them by explaining what happens really. So have them watch this video or my other videos on non-epileptic seizure series, because if they understand it well, they will, their ideas and notions about non-epileptic seizures will change a little bit, and then will be more understanding and more compassionate about their loved ones. So I think that will be very empowering. And other things that we like to treat is to kind of like take a holistic approach, because sometimes there are some conflicts beyond the patient themselves. So like sometimes they have family discord or some unsolved matters outside. They don't have support in her community. They don't have somebody to talk to, and this kind of outside stressors or outside issues, they are affecting their treatment and healing. So addressing that also can be a major step to healing and to improvement and to getting better. And one thing as well we always talk about is like treating any underlying depression and anxiety, because depression, anxiety, PTSD, they often happen with non-epileptic seizures. They don't cause non-epileptic seizures. Most people are like, oh, it's psychogenic, has to be anxiety, depression. No, that anxiety, depression are a diagnosis by itself. Non-epileptic seizures are completely different diagnosis. But if you have untreated anxiety and depression, it can cause symptoms to be worse, harder to control. It's kind of, there is a noise and chaos in the background. It's hard to focus and concentrate. So that's how it is. So it's better to treat any anxiety and depression underlying with medications, with psychotherapy, so that the patient as a whole will improve, and talk about the family, the support environment, the environment that patient is in. It's a holistic approach rather than just tackling the seizures on their own.
Yeah, I've noticed in a lot of forums that some people dealing with living with PNES, they want to have a name for it, because I think that's important for people to actually understand it. And the first thing to understand is just the name. And there's some debate, I guess, on some of these forums that I saw. And I think you kind of touched on it. Some people call them stress seizures. Now, is that an accurate term?
No, I don't think stress seizure will represent it. First of all, the word stress, I have not used it, if you notice, throughout the conversation, because stress is a very kind of broad term that people kind of vaguely do and talk about. And stress is not the cause of non-epileptic seizures. Stressful situation can, but overall stress is not the cause. There are biological mechanism changes in the brain that causes these to happen. And then also most people will have these events after they got trauma. They're not stressed now. So if somebody, for example, got traumatic life experience, has an accident, has an abuse or something like that, they had it like 10 years ago. And when in the heat of the trauma and the heat of the problem, they do not have any non-epileptic seizures. When they come, when they're married, they're in a safe environment, they're in a safe relationship, then their brain kind of like worries about going back and then start to cause this as a defense mechanism. So it can be something that happens later on.
Wow. Have you noticed that there's a certain type of person, certain personality, gender, age, anything that really defines the susceptibility of having psychogenic non-epileptic seizures, or can it just happen to anyone?
So it can happen to anyone, but there are more common in females than males. And it also can be in people with borderline personality disorder. So people who have borderline personality, they are more susceptible to have non-epileptic seizures than other people. But it can happen. It can happen to young people. It can happen to old people. It can happen to males, to females. It can happen to people who never had any traumatic life experiences that they can identify. It can happen to anyone. I have people like started having them in their 60s or 70s.
What are some of the differences between quote unquote anxiety attacks and PNES?
Yeah, there are lots of differences actually. So anxiety attack is it's a mostly like psychological with a physiological response. So for example, somebody with anxiety attack, they will feel that in their brain, that they will feel fear, they will feel impending doom, and then they will have physiological response to it. It means like they are being chased by a bear when they're sitting in their living room. So they will have heart racing, they will have sweaty palms, they will have tremors. So all these like physical changes that happens due to a kind of brain conflict that can trigger it. So this is the anxiety attack. They will be aware of it. They will still be able to control themselves, and they don't shake to the point like they seize. So that's an anxiety attack. And a non-epileptic seizure doesn't have to deal with anything like anxiety. It's a shaking event that can impair the consciousness sometimes, leading to injuries and falls. So it's kind of like quite different than anxiety attacks.
So for maybe someone again is watching, they haven't seen their doctor, they don't know what's going on. They're watching this video for the first time. What are their first steps to getting help?
So the first step is to see a neurologist, because neurologist is the one who can tell the difference between an epileptic seizure, an epilepsy, and non-epileptic seizures. So that's number one. And then they get the best testing available. And we recommend them to be seen by epilepsy specialist, because sometimes, like, if somebody is a general neurologist and not like really experienced in this, they might just go with the symptoms and not really dig deeper and diagnose people incorrectly with epilepsy. And unfortunately, like, studies have shown that people can be misdiagnosed as epilepsy for years, and then later on, like 5 years, 6 years, and then it's like, oh, maybe we give you all the medicine for seizures and it's not working. Let's investigate where the seizure is coming from, and then you bring them to the epilepsy monitoring unit, and then you find that they have non-epileptic seizure. So if you have a neurologist, especially if they're specialized in epilepsy, that's the best one to go to kind of make this diagnosis happen right.
Well, thank you so much, Dr. Danoun. I know this is a really important topic to really discuss, and I hope those who are listening, if they're caregivers, they got a little bit of information and maybe can empathize with these patients. And if you're someone who's dealing with unexplained, maybe psychogenic non-epileptic symptoms, that you do what Dr. Danoun said and go talk to your neurologist. So thank you so much, and we'll have you back on the podcast for sure.
Thank you, girl. My pleasure.